Hi, my friends. Welcome to my today's classroom. In my today's classroom, I will be talking about non-ulcer dyspepsia. This is a functional dyspepsia. Now, this functional dyspepsia is very common in every country, in every population, and this dyspepsia is a very nuisance making problem. Now, what is this dyspepsia? Dyspepsia is a Greek word. This means bad, and pepsia means digestion. So, whenever there is bad digestion, that is known as dyspepsia. There are various classifications of the dyspepsia. In these classifications of dyspepsia, any vague type of complaint which is related to abdomen is known as dyspepsia. If there is bloating sensation, that is also known as dyspepsia. If there is pain in abdomen, that is also known as dyspepsia. If there is distension, post-meal distension, postprandial fullness, that is also known as dyspepsia. So overall, this is a vague term, bad digestion, dyspepsia. So whenever a patient is presenting with, say, pain in epigastrium, distension in epigastrium, and which is more after meals, then we'll say that it is a dyspepsia which is simulating gastritis, which is simulating gastric peptic ulcer. If patient is complaining of retrosternal burning sensation, then it is known as dyspepsia which is simulating esophagitis or gastroesophageal reflux disease. So like this we classify the dyspepsia. If patient is complaining of, say, pain and discomfort after fatty meals or pain or discomfort in the right hypochondrium, then we'll say that it is a dyspepsia which is simulating biliary dyskinesia or simulating cholecystitis, cholelithiasis. If patient is complaining of distension in abdomen in periumbilical region after meals or before meals, then we'll say that this is dyspepsia which is simulating small bowel dysbiosis. So like this dyspepsia is classified. So it is a vague term. So whenever there is any problem with digestion, that is known as dyspepsia. But whenever there are some red flags, that is alarm symptoms, then one should not straight away label a case as non-ulcer dyspepsia. One should work up properly, thoroughly, and then if no finding is seen, if no conclusion is drawn, then you can say that it is functional dyspepsia or non-ulcer dyspepsia. That means it is an exclusion diagnosis. Red flags means if a patient is elderly, above 50 years of age, above 55 years of age, and if he is presenting with dyspeptic symptoms, weight loss, melena, hematemesis, and weight loss is excessive, drastic, then we'll say that there may be some malignancy inside the abdomen. So one should work up thoroughly to rule out the causes, various causes of dyspepsia. Dyspepsia can be caused by, there are two types of dyspepsia. One is organic dyspepsia. This can be caused by esophagitis, pathological esophagitis, NECA esophagus, carcinoma esophagus, or if there is a stricture in esophagus, if there is peptic ulcer, gastric peptic ulcer, or duodenal peptic ulcer, gastritis, gastric erosions, duodenal ulcer, duodenal erosions, all these conditions will cause organic type of dyspepsia. Some drugs like non-steroidal anti-inflammatory drugs, some anti-arrhythmic drugs, some anti-hypertensive drugs, anti-diabetic drugs can cause dyspepsia. Drugs which are used to control diabetes, that can cause dyspepsia. So dyspepsia is caused by many type of drugs also. Apart from this organic and drug-induced dyspepsia, there are certain food allergies are there which can cause dyspepsia. If patient is allergic to particular food, that can also cause dyspepsia. So one must exclude all these things on the historical basis from the history of the patient. Whenever a patient comes to you with such type of problem, non-ulcer type of dyspepsia or dyspepsia, then that particular patient is too much worried about the symptoms. Sometimes he thinks that he is having carcinoma inside, or suppose some life stress has occurred in his family, there is some history of some death in family of carcinoma or cancer in family or in relatives or in friends, then he will think that he has also developed cancer or he has also developed peptic ulcer. So he will try to correlate all those symptoms with the symptoms related to that person who has died. So this patient is feared, terribly feared when it comes to the physician. The personality of physician, way of talking of physician, interaction with patient, this depends a lot. This will help in curing the patient. So medicines plus interaction of physician, doctor is must be very sympathetic. Then only you can cure that patient in a proper way. So this non-ulcer type of dyspepsia, in the non-ulcer type of dyspepsia, there is altered gastrointestinal motility. Now this altered type of gastrointestinal motility is usually seen in gastroesophageal reflux disease. In gastroesophageal reflux disease, when various investigations including endoscopy is done, you may not get any finding in the esophagus, still there is reflux. So this disturbed motility of of the lower esophageal area, of the sphincteric area, lower esophageal sphincteric area, will cause gastroesophageal reflux. So this is known as endoscopic negative gastroesophageal reflux disease. This is also a type of non-ulcer dyspepsia. If there is gastroparesis, which is very common in patients of diabetes, in patients of scleroderma and autoimmune disorders, there is gastroparesis, and this gastroparesis will lead to early satiety, loss of appetite, and reflux phenomena is increased. Gastric emptying is delayed. There is post-meal fullness for a long time. So these all are the features of dyspepsia, non-ulcer dyspepsia. After you have ruled out the cause of dyspepsia, then only you label it as case of functional dyspepsia or non-ulcer dyspepsia. Similarly, if there is bowel dysmotility, because of dysmotility of bowel, emptying time of stomach is delayed, and again there is post-meal fullness. So this may again cause dyspeptic symptoms. And if there is no pathology inside the small bowel, then you will label it as a case of non-ulcer dyspepsia. Similarly, biliary dyskinesia, you will have to rule out by different studies the pathology in biliary tract. If there is no pathology in biliary tract, in gallbladder, then you can label it as biliary dyskinesia. So overall, the intestinal motility, gastrointestinal motility is disturbed in functional type of dyspepsia, in non-ulcer dyspepsia. Number 2 is alteration of accommodation. There is altered accommodation of stomach in a normal person. Whenever a normal person is taking meals, whenever a normal person is taking fluids, then that amount of fluid, that amount of food will accommodate in the stomach. The stomach will accommodate it, and to accommodate it, the fundic area of the stomach will relax. The diaphragm will relax. The abdominal muscles will contract. So fundus will relax and capacity of the stomach will gradually increase. So this will lead to accommodation of food which is entering inside a person, entering inside the stomach of a normal person. So this food will accommodate in the stomach, as a result of which the diaphragm will relax, but abdominal muscles will contract in order to keep food and its motility of stomach at a proper place in a proper way. Now, whenever there is vagal inhibition because of inhibition of enteric nerves, because of nitric oxide, because of serotonin, whenever there is inhibition, this inhibition will elicit this reflex, whole of the reflex, and as a result of stimulation of this reflex, there is relaxation of diaphragm, there is relaxation of fundic muscles, and capacity of stomach will increase. When whole of this reflex is inhibited because of some disorders, then it will lead to abnormal motility of stomach, and accommodation of stomach is decreased. And whenever this accommodation of stomach decreases, in that condition, fundus will not relax properly, abdominal muscles will not contract, they will relax, and the diaphragmatic muscles will contract. So overall, there is intra-abdominal pressure is increased, pressure in stomach is increased, and patient will complain of early satiety during meals. He will complain of anorexia, post-meal, early fullness. So this is a part of functional dyspepsia. Apart from this, in these patients, The visceral hypersensitivity, visceral sensitivity is increased in a normal person when viscera is stretched. At a particular threshold, patient will complain of pain sensation. At a particular level, the patient will complain of sensation of stretching. But in the cases of functional disorder, non-ulcer dyspepsia, similarly in irritable bowel syndrome, this threshold values, this goes down. So patient will complain of pain sensation, patient will complain of stressing sensation at earlier than in a normal person. So even a small amount of gas, it accumulates in the stomach or in intestine, and when small amount of food material enters in stomach and intestine, then patient will start complaining of pain in abdomen, stressing sensation in the abdomen. So there is visceral hypersensitivity, we call it visceral hypersensitivity. Apart from this, certain dietary factors are also there. Some people, they consume alcohol before meals. Patients, they smoke before and after meals. Tobacco chewers, excessive spices are taken during meals. Excessive spicy food is taken, or if food is not chewed in a proper way. All these things, all these dietary factors will contribute to dyspepsia. So in dietary factors, sometimes if fat is consumed in a large amount, if cheese is taken in a large amount, if chocolate is taken in a large amount, then in these cases also motility get disturbed and visceral hypersensitivity is increased. So in cases of management of this functional bowel syndrome, functional dyspepsia syndrome, in non-ulcer dyspepsia, these dietary measures should be taken care of. Another thing is H. pylori, Helicobacter pylori infection. Now this Helicobacter pylori is one of the normal commensals of the stomach, and it is isolated, mostly detected in the cases of antral region. In the developing countries like India, in our country, we have this H. pylori as a normal commensal in the antral region of stomach. It is also said that this H. pylori may cause non-functional type of dyspepsia, that is non-ulcer type of dyspepsia. I personally have worked on this particular H. pylori in about 3,000 cases. H. pylori, role of H. pylori in esophagitis, acid peptic esophagitis, role of H. pylori in non-ulcer dyspepsia, role of H. pylori in peptic ulcer, in gastritis, in duodenal ulcer. So I have done these different studies, and in different studies I have seen that definitely in non-ulcer dyspepsia there is role of H. pylori. In about 1,000 patients I have studied on this non-ulcer dyspepsia. I have taken biopsy from that area. I have done the urease test. I have done the breath test. These were all positive in 70 to 80% cases. So definitely this H. pylori is having some role in non-ulcer dyspepsia. Now, whenever a patient of non-ulcer dyspepsia reaches us, that particular patient should be thoroughly examined. Each and every investigation should be thoroughly done before labeling it as a case of non-ulcer dyspepsia. So whenever a patient reaches you, you must first think on the line of organic dyspepsia, and at the end, when nothing is found in favor of that dyspepsia, now no pathology is found, then you can label it as a case of non-ulcer dyspepsia. That is, it is an exclusion diagnosis. So the first procedure which is to be done, earliest to be done, is endoscopy. That is upper GI endoscopy, gastroduodenoscopy. With the help of endoscopic study, you can rule out esophageal pathology, you can rule out gastric pathology, any malignancy, any erosion, any inflammation, any duodenal inflammation, malignancy or erosion. So you can rule out all these pathologies with the help of upper GI endoscopy. Upper GI endoscopy is very helpful in excluding the organic cause of dyspepsia. Second thing which is to be done is ultrasound of abdomen. With the help of ultrasound of abdomen, you can diagnose the biliary tract pathology. You can diagnose pathology in pancreas, in liver, in gallbladder, which can cause this type of dyspepsia. Similarly, CT scan of abdomen can be done to rule out any pathology in the abdomen which is causing this type of dyspepsia. So thorough investigation is must. Apart from this, one must go for H. pylori breath test. You can do urease test to diagnose H. pylori and treat it in a proper way to treat this non-ulcer dyspepsia. Then you must go for study on psychological factors, because psychological factors, these are very important in cases of non-ulcer type of dyspepsia, in functional dyspepsia. In psychological factors, anxiety, the exam stress, any type of anxiety, depression, any degree of depression, this can lead to non-ulcer type of dyspepsia. Apart from this, life stress, that is death in a family or somebody is too much ill in the family, he is hospitalized, again this will contribute to dyspepsia, because all the functions of gastrointestinal tract and overall whole of the body is controlled by the brain. So whenever there is any stress in the brain, whenever there is chemical imbalance, hormonal imbalance in the brain, that will lead to functional type of dyspepsia. So psychological factors should be studied in a proper way in that particular person, and for that you will have to give some time, doctor will have to give some time to in order to get to these psychological factors. So you go for proper psychiatric evaluation to rule out anxiety, to rule out life stress, to rule out depression. And once you have ruled out all these things, definitely you can treat a patient in a proper way. Apart from this, to relieve the symptoms, you can use proton pump inhibitors, simple histamine blockers. You can use H2 blockers like ranitidine, cimetidine, famotidine. These can be used in these cases to get relief from the symptoms. You can get relief from the symptoms by simply giving plain antacids. If patient is feeling as if he is having too much gases, you can use simethicone. So you can use these drugs to relieve the symptoms. Apart from this, you can use prokinetic agents. In prokinetic agents, you can use all type of prokinetic agents like etopride. You can use levosulpride, and these drugs can be used to control the gastric motility, intestinal motility. If you think that there is small intestinal dysbiosis, that is overgrowth of bacteria in the intestine, then you can treat it with the help of probiotics. So probiotics is also having a role in this non-functional type of dyspepsia. Apart from this, use triple therapy, that is 1-2 antibiotics and proton pump inhibitor for at least 2 to 3 weeks to cure the patient from Helicobacter pylori, H. pylori. I personally, what I do, that I don't go for H. pylori test, because H. pylori test itself is very costly, and with the help, simply by giving this triple therapy for 2 weeks, you can cure that H. pylori infection. That much of money can be utilized in treatment. So like this, you will treat a patient of non-ulcer type of dyspepsia, functional dyspepsia. The one most important thing is dietary modification. You will ask patient not to use junk food. Then in these patients, it is seen that immunoglobulin G, level of this immunoglobulin G is elevated if there is food intolerance. So you can go for serum level of this immunoglobulin G against a particular food material. But this test to detect food intolerance is very costly. In our country, the cost of this test is 14 to 15,000 per patient. So you can go for this test if patient is feeling too much discomfort, and if there is food intolerance, then ask that patient to avoid that food which is causing disturbed motility, which is causing non-ulcer type of dyspepsia. So dietary modification is a must. You always tell patient not to take junk type of food. Always tell patient to take fibrous food material. So dietary modification is must in these patients. If patient is diabetic, Tell him to take diabetic diet and control the diabetes in a proper way. So like this, you will ask patient to modify the dietary habits. Then ask patient to change the lifestyle. If lifestyle is sedentary type of lifestyle, ask patient to do regular exercises. Ask patient to do relaxation exercises, jogging, running, dancing, swimming. These all exercises will help a lot in non-ulcer type, non-functional, dysfunctional type of dyspepsia, non-ulcer type of dyspepsia. So always ask patient to do exercise, reduce body weight. Apart from this, you will have to keep in mind one thing, that is the endocrinal disorders. Always rule out endocrinal disorder before labeling a patient as a case of non-ulcer type of dyspepsia. If there is associated endocrinal disorder like hypothyroidism, diabetes, or Addison's disease, these types, hyperthyroidism, these all diseases always affect the gastrointestinal motility. So this should be kept in mind, and investigate for the hormonal levels also. So this is all about functional type of dyspepsia, non-ulcer type of dyspepsia, and this is one of the very common problem in clinical practice. So I will ask the physicians, I will suggest the physicians, gastroenterologists, to give some time to the patients for interrogation, convince them, and it will help a lot, and you will able to treat this patient in a proper way. Thank you.